So the list of biologics in bone is short. It includes Denosumab, which is a fully human monoclonal antibody against RANKL. And that's the only one we have at the present time. But shortly, we're going to have on the anabolic side, we hope, a drug called Romosozumab, which is an antibody against sclerostin, sclerostin being an inhibitor in the Wnt signaling pathway. Now notice that Denosumab is a UMAB, so it's fully human, and Romosozumab is a ZU, so it's humanized, so it still has animal protein in it. So this is the RANKL pathway. RANKL is produced predominantly by osteoblasts, and this pathway was really discovered in 1997 when DNA from a cDNA library was inserted into mice to overexpress certain genes, and in this case from the TNF family. One of the strains had very high bone mass. And it turned out that that strain overproduced a molecule called OPG, which is an inhibitor of RANKL. So inhibition of that allowed a decline in bone resorption and an increase in bone mass. Subsequently, RANKL was discovered, and within 13 years, from 1997 to 2010, we have a drug on the market, Denosumab, which is a really fairly rapid drug discovery process. So Denosumab, as you can see here, is really mimics, in a way, OPG to inhibit RANKL, decrease bone resorption, and increase bone mass. And RANKL is essential for not only function of osteoclasts, but also for production, because patients and animals who have no RANKL knockout mice, are osteoclast poor and get osteoporosis. I want to remind you about the FREEDOM trial, which was a trial that led to the approval of Denosumab. It was a 36-month trial with 7,800 patients that resulted in a 68% reduction in vertebral fractures, a 40% reduction in hip fractures, and a 20% reduction in non-vertebral fractures. And to the sponsor's credit, they enrolled 4,550 patients in a 10-year extension, 7 years additional, that actually the extension has given us some very valuable information about the mechanism of action of Denosumab and has kind of distinguished it from bisphosphonates, and that's what we want to talk about today. So this drug is unique in many ways. First of all, of course, it's a biologic. Second, unlike the bisphosphonates, it has a very rapid offset when discontinued, and that has implications for our drug holiday paradigm that we all talk about today. When you continue Denosumab, you see a continued increase in bone mass, and that again is unlike what we see with the bisphosphonates. It appears that Denosumab has a different effect on cortical bone and subsequent potentially different effect on long-term non-vertebral fractures. And it can be used in patients with CKD, as you know, because it's excreted by the RE system, not by the kidney, as monoclonal antibodies are. And unlike bisphosphonates, which blunt the effect of teriparatide, the use of Denosumab with teriparatide is actually additive. So this is what happens when you treat with Alendronate for 2 years and then discontinue. So you can see that there's a very small decline in bone density 1 year after discontinuing the drug, almost negligible. And you can see there's a very small uptick in a marker of bone resorption, NTX. So when bisphosphonates are used, they bind to bone, they stay there a long time, and if this this graph showed a 5-year treatment with bisphosphonate, the decline in bone mass and the uptick in NTX would be even less because of the residual effect gets greater the longer you use the drug. Now, this is very unlike what we see in denosumab as seen here. You can see when the last dose of denosumab is given at 18 months, so you have 24 months effect because you have 6 months of drug left, and discontinue by 36 months or 12 months after discontinuation, bone mass is back to baseline. So a very rapid offset. And even in the phase 2 trial with 8 years of treatment of denosumab, within 1 year after discontinuation, about 50% of the bone mass is lost at 1 year. And so that obviously has implications for drug holidays. The same thing happens on the hip, as you can see on the right. And that's in part related to what's happening with markers of bone turnover. You can see that when you, again, give the last dose of denosumab here at 18 months, you can see at 6 months after you should have gotten your dose, you have almost a hyper-resorptive state where, in this case, CTX, another marker of bone resorption, is actually higher than baseline and actually continues to go up for another 6 months, creating that hyper-resorptive state that results in a rapid, what we think is a rapid bone loss that I showed you on the previous slide. And the same thing happens with a marker of bone formation on the right. So this is what happens when you continue denosumab for 6 years in the top. This top line up here is the lumbar spine density, and the top line is those patients who were in the original Freedom trial treated with denosumab and then continued with denosumab. And that increase that you see for 6 years is quite unlike what we see with bisphosphonates, where we have a real flattening of the increase in bone mass after 2 or 3 years with no further increase. And the mechanism for that is somewhat unclear because both decrease bone formation, and denosumab even more so than bisphosphonates. But nevertheless, that is the data, and that confirmed what we saw in the phase 2 trial through 8 years where the increase continued. This is a 15.2% increase in lumbar spine density through 6 years, and in the phase 2 trial at 8 years it was about 16.5%. On the right, you can see the data from the randomized control trial for non-vertebral fractures for the first 3 years showed a 20% reduction in non-vertebral fractures, and that's about what we saw in the randomized control trials with the other anti-resorptive agents like Fosamax and Actonel. But notice in the extension trial, the non-vertebral fracture rate is now about 50% lower. Now, there is no control group, obviously, so there's no placebo group. So what's been done is to construct a mathematical model to recapitulate what the placebo patients in the first 3 years would theoretically do if we had a placebo group in the next 3 years, and that's called a virtual placebo or a virtual twin model that you see here, and that's how they calculate the reduction in non-vertebral fracture, which goes down from 6.5% to 3.8%, an additional reduction through 6 years for non-vertebral fractures. And that's also, I think, quite striking, but has to be taken with a grain of salt since it's not a randomized controlled trial. So this is what happens in cortical bone when you have high turnover. Remember, cortical bone has a bit of a different remodeling paradigm. In trabecular bone, remodeling is surface-based, whereas in trabecular bone, it's tunneling-based. So the Haversian canals that you remember maybe from med school are holes within cortical bone. And as cortical bone remodeling increases, you get increases in these cortical holes or pores, and that's what we call increased cortical porosity in bone. And that obviously has a deleterious effect on fracture risk, particularly non-vertebral fracture risk. And you can see that can become quite significant over time. This is what it looks like in a rat femur. On the left, you see a rat that's been oophorectomized, and you can see the tremendous cortical porosity here in the cortex. And you can see denosumab decreases the increase in cortical porosity seen in this estrogen-deficient model quite significantly. We have actually data on humans that show the same thing. This is a study of actually 247 women by high-resolution PQCT looking at the increase in porosity on placebo, alendronate, and denosumab. And when you compare the increase in porosities, you can see that denosumab results compared to placebo about an 8% decline in porosity, and even compared to alendronate, a 5% difference in the porosity. And that, again, has a tremendous effect probably on non-vertebral fracture reduction. So this is the data from the FREEDOM trial again, but this is a subset of patients who are over 75 years of age. And notice the Kaplan-Meier curve here shows quite an impressive increase in difference here with a reduction in hip fractures in that over 75 age group over time. Much greater than the whole cohort, much greater than those younger than age 75. So a subset of patients from the FREEDOM trial, about 80 patients, had what's called 3D cortical mapping, where a regular CT is done, and cortical thickness is measured, and then a color map is placed on the femur. It looks like this, and you can see the colors represent increase in bone mass in various locations. And this can detect changes as low as as small as 30 microns. Okay, and you can see, interestingly, that the most increase in cortical thickness is occurring at the trochanteric region, much more than the femoral neck even. And it's interesting, if you actually think about the data, the reduction in the over 75 in hip fracture for femoral neck was about 50%, but for trochanteric fractures was about 70%, even greater. And that's actually where the greatest increases, up to 12%, increase in cortical thickness are occurring based on this color mapping model. Another unique part about denosumab is its risk for infection. We've heard a lot about infection risk with biologics today. So the FREEDOM trial had a signal, and that signal was related to 12 cases of cellulitis out of 3,886 patients who were in the denosumab section group. And so the question is that significant, and is that of concern to us as rheumatologists and to people who treat osteoporosis? Because it resulted in a label that says patients on concomitant immunosuppressant agents or with impaired immune systems may be at increased risk for fracture. So most of us have taken that not to mean methotrexate, not to mean non-biologic DMARDs, but have taken it to mean biologic DMARDs where infection risk is already increased. So why is that a concern? It's somewhat disappointing that we're hesitant to use denosumab in our patients on DMARDs because the drug is effective. There's a GIO study ongoing, so it presumably will be approved for GIO. And as you know, Stan Cohen was here the first couple of days, and this is his study that actually showed that 180 milligrams of denosumab reduced erosions in patients with rheumatoid arthritis, both by MR and by regular Xray using sharp scores. This is because erosions are osteoclast-driven phenomenon. Okay, so they're not pannus-driven directly, they're osteoclast-driven. So animals that are osteoclast-depleted do not get erosions in animal models of rheumatoid arthritis, but they do get joint space narrowing because that's a different mechanism. So there is biologic plausibility for why RANK ligand might be associated with an increased risk for infection. RANK ligand is not only expressed by osteoblasts, but also by activated B cells and T cells and dendritic cells. And in RANK and RANK ligand knockout mice, they demonstrate lymph node agenesis, so they have germinal centers that are completely altered with altered thymic architecture, but with normal dendritic cells and normal macrophages. On the plus side, humans, the few humans that actually have a genetic defect that results in rank ligand deficiency and thus have osteoporosis seem to have minimal or no increased risk for infection, and this deficiency does not cause infection risk. And then primates and rats who have been treated with pretty much lifelong rank ligand inhibition also don't have infection risk and have minimal or no effects on T or B cell responses or on immunization responses. So I guess the question is this risk overblown? Is there too much of a concern for this? My own personal feeling is that it probably is. This is data from a trial looking at comparing Denosumab used in extremely high dose in oncology, Xgeva. So this is a dose of 120 milligrams a month. Remember, we're giving 60 milligrams every 6 months. And the purpose of this study was to compare ZA with DMAB for adverse skeletal events in breast cancer patients. So it wasn't, the purpose of this wasn't to look for infections, but notice that the infection rate in the Xgeva cohort was actually slightly less than in the ZA cohort. And this is an immunosuppressed population who is getting active cancer treatment. Now, there was one interesting thing from this study, and that's the extremely high risk of ONJ that you see here in a cancer population getting very high doses of anti-resorptive agents. And for DMAB, 2% of the patients got ONJ. So that raises the issue of ONJ in osteoporosis populations. So what exactly is that risk? Last year at ASBMR, Nelson Watts presented data on infection or ONJ risk in patients in the Freedom trial who were undergoing what's called invasive oral procedures. And these procedures include what's called deep scaling or root planing, and that actually requires anesthesia. If any of you have ever had that, that's not just simple dental cleaning. It includes tooth extraction, dental implants, tooth loss, and jaw surgery. And so there were about 1,500 oral procedures, including 741 dental extractions. And in those patients who had these invasive oral procedures, there were 8 cases of ONJ, 6 resolved, 1 is ongoing, and 1 was lost to follow-up. So when you look at the exposure-adjusted incidence here, it's about 4.2 per 10,000 patient years. And it's estimated that without any dental procedures and with normal dental hygiene in our osteoporosis population, the rate is about 0.4 per 10,000. So there does seem to be an increased risk with invasive dental procedures. The nice thing is, remember, when you stop DMAB, the effect goes away quickly. If you want to time your invasive dental procedure, I would do it at the end of the 6-month period or even delay it a month or 2 and let them heal. So that's the nice part about DMAB. But having said that, the rate of ONJ, even with invasive dental procedures, is only about 1 in 2,000 per year, a pretty low risk. The other unique feature of DMAB is its use in patients with CKD. And this is the study not to look at really that aspect, but to look at whether or not DMAB was effective across different levels of creatinine clearance. And you can see that in patients who have CKD4 with a GFR between 15 and 30, that DMAB is as effective at reducing vertebral fractures as any other creatinine clearance group. But from this group, essentially, we have the feeling that this drug can be used, unlike bisphosphonates, in patients with moderate and even severe degrees of renal dysfunction without concern. And that makes sense because, again, it's excreted by the RE system, not by the kidney, as bisphosphonates are. I do want to caution you about using DMAB, and I see my colleague Bruce up there shaking his head because he knows very well the effects of DMAB in patients on dialysis. This is a study of patients getting DMAB on dialysis who have severe secondary hyperparia. Look at the PTHs; they're all over 1,000. And notice that in 4 of these 12 patients, the serum calcium drops below 7. And in some cases, that can result in hospitalization and significant cardiac effects. And this occurs because, remember, these patients don't have kidneys to regulate calcium on a minute-to-minute basis. They are very dependent on bone turnover to supply calcium to the serum. And when you turn off bone turnover that rapidly, you can get a significant drop in serum calcium, which occurs in the first several days, sometimes maybe 3 or 4 days later. Interestingly, though, when they went back and gave all their patients 3 grams of calcium a day, 2 micrograms of calcitriol, or 125-hydroxy-D, and increased the dialysate from 3 to 3.5 milliequivalents, they saw very little hypocalcemia. And notice the increases in bone mass, which you might expect here in a subset of patients with really, really high bone turnover because of secondary hyperparathyroidism. Another unique feature is the use of this drug in combination with teriparatide. This is the PATH trial, which showed basically that using alendronate with teriparatide reduced the increase in bone mass. This is by QCT. This is why the numbers are so big, from 25 to 12%, which resulted in us not using concomitant therapy of teriparatide and bisphosphonate. This is the results from the data trials showing an increase in bone mass in combination therapy, teriparatide plus denosumab over here on the right-hand bars, both in the spine and in the hip. And you can see the increase in the combination group was 12.9% compared to 8.3% with DMAB alone, and 9.5% in the lumbar spine with DMAB alone. Okay, and the reason probably that occurs is because of the effect on cortical porosity. I'm not going to go into detail for lack of time, but notice over here on the porosity graph, the significant increase in cortical porosity seen with teriparatide. So teriparatide increases bone resorption and increases cortical porosity, and denosumab combination blunts the increase in cortical porosity and probably improves cortical bone quality. Okay, so the last part of the talk, I just want to talk about the anabolic side. Romosozumab. Blozozumab is not going to be available because just actually this week, Lilly decided that it wasn't going to proceed with phase 3 trial because they were having problems with injection site reactions with the drug, but that's not a problem with romosozumab. So this is an interesting X-ray of a patient, several patients with sclerostosis. And this is an experiment of nature which gave new insights into biologic mechanisms, because the patient in the middle is an adult homozygous with sclerostosis, and the patient on the right is a heterozygote with sclerostosis. And notice the difference in bone mass in these two. So that tells you that it's dose-related in terms of the genetic effects. And it turns out that this disease, which has occurred in only a few hundred people, and mostly in South Africa, is caused by a gene mutation that results in a deficiency of sclerostin, the SOS gene. And so in order to understand that, this is a simplified view of the Wnt signaling pathway. And you can see that the key players here are 2 membrane proteins called frizzled and LRP5, which in the presence of Wnt associate and create this cascade where beta-catenin is translocated to the nucleus, and osteoblast important genes are upregulated, and osteoblast production and function occurs. So SOS, or sclerostin, inhibits this process. So SOS deficiency, as you see with sclerostosis, results in marked acceleration of Wnt signaling and marked increase in bone mass. And that is actually recapitulated when you produce an antibody to SOS, which is essentially what romosozumab is. It is a humanized monoclonal antibody against sclerostin. In order to understand why this drug is so attractive, you need to know a little bit about osteocyte biology. Osteocytes are the most abundant cells in bone. They are 85% of all the cells in bone, more than osteoclasts, more than osteoblasts. And osteocytes are osteoblasts that have sunk into the matrix, as you see here, and created this unique canalicular system, which creates the communication system in bone. And this is a very attractive drug target because it turns out that osteocytes are the only cells in the body that produce sclerostin. So an antibody would expect it to be on target. There would be no off-target effects with this medication. And in addition, osteocytes do not divide. So you would expect not to have any tumorigenesis issues related to manipulation of osteocyte population. So it becomes a very attractive way to manipulate the Wnt signaling pathway. And that's essentially what's been done. This is the results from the phase 2 trial, which were published in the New England Journal by Mike McClung last year. 419 patients given 210 milligrams monthly, remember, see Q month, not QD, like teriparatide, versus an alendronate and placebo. And you can see the increase in bone mass with romosozumab was 11.3% in the spine compared with 7% for teriparatide and 4% for alendronate. And surprisingly, the drug resulted in an increase in a marker of bone formation, P1NP, that was very rapid, 1 month, but went back to baseline within 6 months, 6 to 12 months. But despite that, bone density continued to increase through 2 years, as I'll show you on the next slide. And even more surprisingly, CTX, a marker of bone resorption, didn't increase as we see with teriparatide, it decreased. So it's both a bone formation agent and an anti-resorptive in a way. It's a very unique compound. So we have kind of a new paradigm. On the left, we have what happens with PTH, where you get not only an increase in formation, but an increase in resorption, and that difference is what we call the anabolic window. And on the right, you see romosozumab, where that anabolic window would be expected to be greatly expanded because it's not increasing the resorption side of the equation. In fact, it's decreasing the resorption side of the equation. An additional year of romosozumab resulted in additional increases in bone mass, as you can see here. And discontinuation, like DMAB, results in rapid loss of bone. So again, an issue for our drug holiday paradigm that we'll have to deal with when this drug comes out, hopefully at the end of 2017 is the anticipated delivery date, we hope. You can see after 24 months, the increase in bone mass is 15.7%. And then when you use denosumab for 12 months after discontinuation of the Romo, you get an additional increase to almost 20% at 36 months. And that's a T-score, would be a T-score in your patients of +2. So they would go from -3 to -1 based on these numbers. So you can see the difference between teriparatide or other anabolic and Romo. The dosing is different. We think the duration of treatment is probably going to be 1 year, followed by denosumab. That's the way the randomized controlled trial is set up. The markers of bone turnover are quite different, as I've mentioned, and the increase in bone mass is more robust with romosozumab. And this is the cortical difference in romosozumab versus teriparatide. The last thing I want to just briefly mention before I stop, notice that the cortical differences are quite significant up here as you go down. The cortical thickness is greater with romosozumab, 157 versus 61. Cortical BMD is greater, apparent cortical BMD, both periosteal apposition and endosteal apposition are greater. So biologics for bone are here with denosumab, and hopefully in 2017 we'll have a second one called romosozumab with potential advantages to our current anabolic therapy. And I want to thank you for your attention.